Now, for our last session today, we are going to be hearing from Professor Carlos Pavezio, who has not been able to join us live today, unfortunately. At the very last minute, he's had to drop out. However, he's very kindly recorded his session that we're going to be able to watch along, and he's also recorded some answers to questions that were sent in advance. So we will load up his session in just a second. Carlos Pavezio, I'll give you a brief introduction before we play the video. He is a professor of ocular inflammation and infection at UCL in London and consultant ophthalmic surgeon at Moorfields Eye Hospital. He is the co-director of the uveitis service, as well as being the editor-in-chief of the Journal of Ophthalmic Inflammation and Infection. So we will load up Professor Pavezio's video.
Good afternoon to all of you. It's a pleasure to be speaking to you today on this special day on sarcoidosis. My topic will be the treatment of sarcoid uveitis. In terms of our objectives, our primary aim is to restore vision and prevent complications which can result from uncontrolled inflammation or chronic inflammation. Corticosteroids, in terms of topical, regional, or systemic use, still remain our mainstay of treatment to induce control, like a big fire extinguisher to control the fire. And then, of course, we still have to deal with the long-term issues of a chronic disease. But in the initial stage, the use of steroids becomes our main tool. Other immunomodulatory therapies may be required in some patients who are dependent, unresponsive, or intolerant to the steroid therapy. In terms of general goals for uveitis management, we want to identify the cause, control the inflammation. We want to prevent recurrences because there's a cumulative effect of damage when inflammation keeps returning. We want to prevent loss of visual function, not only in terms of visual acuity, but also visual field. We want to prevent and treat complications which may be related to the inflammatory process and avoid collateral damage as much as possible. What treatment choices we have for non-infectious intermediate or posterior uveitis in which sarcoid fits in? So if you have an anterior disease, the local therapy would be appropriate with topical steroids, but then you have also the option of using local therapy for posterior disease, and that involves periocular injections or intravitreal injections or devices, which I will explain in a minute. And then we have systemic therapy. Again, steroids become your first option, and then considering the different routes that you can use steroids, oral, intramuscular, intravenous, then our more traditional immunosuppressants, and most recently biologics. What are the clinical factors and other factors we have to take into account when making decisions about treating our patients? So the location of the inflammation, the severity and duration of the process. You want to consider the evaluation of vision and the prospect of this being reversible. So visual changes that we believe can be rescued by our interventions. If it's in one eye or both eyes that are involved, and the presence of any other concurrent systemic disease for which treatment may be required. We can't forget the general health of the patient, potential drug interactions or adverse events that he may have, secondary effects of treatment on comorbidities, and the patient compliance. So the decisions will really focus on targeting the main site of inflammation. If it's a severe inflammation, we have to be more aggressive, and we have to take into account the damage already caused and how much of that can be reversed. Never forgetting other illnesses and other medications that are being used. So for an anterior uveitis that you see here, a typical sarcoid type anterior uveitis with these large deposits on the back of the cornea, topical steroids still remain the mainstay and could be either dexamethasone, prednisone acetate, or with the night ointment or not. And not only we want to fight the inflammation, but we want to prevent a complication like you see here. This pupil is completely stuck down, and we need to use dilating drops like cycloplegic drops like cyclopentolate, more powerful in the early stages, and then potentially a weaker form like tropicamide to mobilize the pupil and allow to prevent these adhesions, which are serious in terms of the consequences to pressure and even vision. Posterior segment involvement could be in different forms. In sarcoidosis, we can see vasculitis, we can see just a vitreous that is very heavily involved, a lot of vitritis, or we can see retinal, especially choroidal disease. So all these forms of disease in the back of the eye have the potential for leading to reduction in vision, affecting visual function in general terms. So it's important that it's well treated, well controlled. The regional injections have not been widely used anymore because some studies have demonstrated they have less efficacy when comparing to the intraocular approach, and they involve the periocular injection, which is what you see here, so putting a little further away from the eye, like an orbital floor injection, or a posterior septinous injection, in which we put the medication much closer to the back of the eye and hopefully having a bigger effect. There's no real big difference between them, slightly superior to posterior septinous comparing to the orbital floor, but they are injections that we have no longer used, as I mentioned before, for reasons related to efficacy, comparative efficacy to the intraocular approach. Intravitreal injections using the triamcinolone acetonide have been very frequently used. Triesence is a formulation which is preservative-free. There are other formulations available which are similar and cheaper, and they're very helpful because they put a very large dose of the medication right where you want it to be, right to the back of the eye. And the duration of that effect in someone who has not had surgery to the eye, no vitrectomy, will be about 3 to 4 months. Very powerful, very effective, but they have problems related to mainly cataract and pressure problems. So especially considering the duration of the effect is limited, you are entertaining several of those injections in the course of time, which will have a cumulative effect of the potential side effects that I'm mentioning here. Implants have come because the injections need to be repeated so often that it would be ideal if you could put something in the eye which will have a more prolonged effect. So the Ozurdex, which is the one you see there, is an injection that puts this little pellet of the dexamethasone implant, which is biodegradable, will disappear after about 6 months, and most of the times the benefit is seen for about 4 months. Of course, repeated injections may be needed as well, and they also can lead to cataract and pressure issues, but this is a better option than the triamcinolone, which is licensed for use and less likely to produce other problems. There's another implant which will last a much longer time called fluocinolone acetonide implant, or commercially available Iluvien in Europe, also given under local anesthetic. Again, there is an injector that puts this little rod-shaped device into the eye and allows the release of the drug over a much more prolonged period of time, for about 36 months. It also connected to cataract and pressure issues. So you've seen that any steroid in the eye, depending on how long it's there for, how many times you need to repeat the procedure, carries a risk of cataract, which is a certainty, and pressure issues, which can happen and may be sometimes tricky to control, but by far controllable with drops. So the choice for local therapy using the approaches I just mentioned to you would be obviously for unilateral disease or asymmetric disease. If the eye is the only problem, so as I mentioned before, if there's no systemic involvement that requires treatment and the eye is the only part that needs to be treated, then the local therapy also becomes appealing. If there's a contraindication for systemic therapy or an intolerance to the use, which sometimes happens, patients cannot make use of the drugs or cannot tolerate them for very long. Some diseases are likely to respond better to the local choice, such as intermediate uveitis or retinal vasculitis. Systemic therapy is usually used for bilateral disease. It doesn't mean that bilateral disease cannot be treated with local options. Yes, we can use local therapy for bilateral disease. It involves treating the two eyes independently. The advantage of systemic therapy is if there is a disease systemically that is leading to the problem, which many times is the case in sarcoidosis, then that treatment will treat the whole package, the whole everything, while the local therapy is only treating the eye. So steroids are usually used in the beginning of the high dose to induce control, then they're tapered, and in the process of tapering you realize that in many patients the control is lost, and then you have to increase the steroids again, and doing that alone without anything else will repeat the cycle. So in these cases you introduce a steroid-sparing therapy. What is the normal procedure for this? There is a systemic cascade here. So you start with the steroids, then you reach the point when you decide you need a second-line agent, and most of the times an antimetabolite such as mycophenolate or methotrexate or azathioprine, with methotrexate being a very good drug for sarcoidosis. What happens here is we do use some T-cell modulators. You've heard of cyclosporin or tacrolimus, but these are not now in such a favorable position. We don't like to use them very much. We use them, but when really the best alternative with some diseases are better controlled by them. What we're doing here, the gap I left there is because we have been introducing in recent times the biologics. And the biologics come in usually now after failure of the antimetabolite. And the most frequently used would be an anti-TNF drug called adalimumab, which is the one which has been NICE approved for use in non-infectious uveitis. So these are usually our normal treatments. There is an option of using a more aggressive therapy in very bad cases, which we very infrequently use in sarcoidosis. So these are the options that are systemically more suited for cases of sarcoid uveitis. The oral steroid first, an antimetabolite, probably favoring methotrexate, and then if that fails, the introduction of the biologic therapy. The problem with steroid is exactly what is written here. They're used for too little and for too long. So steroids have to be used appropriately. If it's a severe problem, a high dose, and then you gradually taper. So if you keep a low dose for long periods of time, you end up getting more side effects than benefits. The systemic immunosuppressants, I mentioned them before, the antimetabolites, azathioprine, methotrexate, mycophenolate are the drugs of choice. And then, of course, the T-cell inhibitors that I said not using as much, and the alkylating agents, which are very rarely used, especially in sarcoidosis. So the problem with these drugs is they all have side effects. They all have to be closely monitored, and they need expert personnel to look after the patients with regular assessments and making sure no side effects are going to be causing significant damage to any other organs. The biologics have been introduced as a way of targeting more specific parts of the immune response. So you manufacture the antibodies which will target elements of this response, like the TNF alpha, which is tumor necrosis factor alpha, a very central element in this cascade of responses in the immune system. So by targeting that, we're blocking the effect of this pro-inflammatory element and hold the inflammation under control. So they are more expensive, but now being approved and we can use them in the NHS and they are very helpful. And sometimes, of course, they don't work. As all drugs, they don't work for every single case that we treat. But this represents a very good initial step. There are other options within the anti-TNF family, and they sometimes are explored if adalimumab is not working, which is the NICE approved drug. And recently we've been using more what we call biosimilars, which have the same efficacy, but are not the same drug and cheaper in the sense of what NHS is looking for. These are just an example here of all these targets that are identified. So all these little markers you see on the cell surface, they have implications for how the cell responds immunologically and how the body presents the antigens to them and how they respond to that. So by identifying these markers, we can create blockers that will allow us to prevent the activation, the wider activation of the immune system, and hopefully stop the inflammatory process damaging the tissues. This is just to show you that the adalimumab was approved on the basis of 2 trials, which looked at the inflammation in active uveitis, the problem in active uveitis, and also in inactive uveitis. And it demonstrated in both studies, Visual 1 and Visual 2, that adalimumab was successful in controlling active disease and preventing activation of disease that was under control. So that's the reason why it was approved, it's licensed, and we are currently using in a larger scale. So in terms of our overall decisions, we look at severity of the presentation, we look at the location, which has very profound implications for the risk of visual loss. So posterior disease involving the very central part of the retina, much more risky than an anterior disease inflammation. The risk of visual loss, of course, if it's immediate or prolonged, so we have to look at preventing complications, as I mentioned before, treating macular edema aggressively, dealing with cataract when it happens, and making sure that the pressure control is adequate. The general health of the patient that cannot be forgotten, because many of the treatments that we might be using will have implications to someone who has already got a renal problem or a liver problem, and we don't want to complicate things. We have to be very careful with the choice of the drug and with the monitoring process. The side effects, of course, will have to be carefully monitored and dealt with, and of course, we cannot forget quality of life. It's not uncommon, and you are all aware of that as users of some of these medications, that they can cause problems that are unpleasant. and may change your quality of life. So we're looking for options that are less likely to result in this. And the local alternatives are very good from that point of view, but they don't come free of problems, as I mentioned before. So this process is not a process that is very simple. I made it as simple as possible here, but all these variables have to be in our minds all the time. And discussions with the patient to explain this and make sure the choices are agreeable to both sides are really very important. I hope this gives you a very good idea of alternatives that we use for the treatment of non-infectious uveitis, and sarcoid is one of them, and how those choices are made. Thank you for your attention.
Thank you very much to Professor Pavesio, who recorded that last night as he found out he couldn't be here with us today. And he has also recorded a second video answering some of the questions that had been sent in advance. Now, obviously, because he's not here live, he won't be able to take live questions, but he has recorded some answers to ones that were sent in advance. So we'll show you those.
Yes, I'm going to try to answer questions which were sent to me. Starting with this one here, that after starting methotrexate for a sarcoidosis flare, woke up the next day and couldn't see very well. So the question here, is it related to the methotrexate? What is to do with sarcoidosis in the eye? What else could be causing that? Considering that you just started methotrexate, it's not going to be the drug that is causing that. It's too quick for any side effect of a systemic drug to produce a change in your vision. It's very possible that there is some manifestation of sarcoid in your eye, which wasn't previously detected, and it needs to be assessed because that's more likely the reason for that. You already have a diagnosis of sarcoid. It's possible that your eye is showing some changes related to that, and the treatment hasn't really been enough to control anything, but it's not really the cause of the problem. So you need to get that assessed because there might be a good reason why your vision changed. The other questions here, how can I deal with constant conjunctivitis? Well, conjunctivitis-like symptoms in sarcoidosis are likely to be connected to dry eyes. Dry eye is a very common manifestation of sarcoidosis because of lacrimal gland involvement. What I suggest is that needs to be assessed, and potentially the regular use of lubricating drops will provide control of the symptoms. So that would be my first take on this complaint. The issue of the bilateral anterior uveitis keeps recurring. Current daily dose of steroid drops. What's the best way of managing that? Well, if your uveitis can be controlled on a very small frequency of drops, like once a day, twice a day drops, then I would say this is the best strategy to use in your case. I would prolong the use of the drops for as long as necessary, and then make sure that you stay stable. I wouldn't be considering the introduction of systemic therapy or any devices and injections for this kind of problem. Low-dose steroids once or twice a day is unlikely to result in significant problems in terms of pressure or cataract, and those can be monitored anyway. So if the problem is when you run out of the drops, you finish the drops, that's when the uveitis recurs, then a small dose, a low frequency might be enough to keep it under control. That would be the route to follow. If you're needing 4 drops or more a day to keep it under control, then that route is not acceptable, and we need to consider introduction of systemic therapy. Pain in your eyes. It depends on the reason for the pain. It could be surface related, it could be inflammation related. It's difficult to tell you without a more specific reason for the pain. It's a question of identifying why the eye is painful and the many reasons why it can get painful, and then deal with that problem. So I'm afraid I cannot answer that very directly. And the final question here, the poor vision that fluctuates. That's another tricky one to reply without an assessment. There are reasons why vision can fluctuate, inflammation itself, but unlikely to be fluctuating as you describe, and improving and then getting worse again. When you have fluctuations, sometimes think about fluid. So macular edema to a certain extent can go up and down, and that's another reason why sometimes vision can change. Cataracts certainly not. Cataracts do not behave that way. And reduction of vision cataract is a progressive deterioration over a gradual, over time. So I wouldn't expect that to be responsible for fluctuation. So if there's a corneal problem, again, I think it's a difficult one to answer without a proper assessment. So I'm sorry I can't give you a straight answer, but an assessment will certainly help us understand the potential reason why the vision has been fluctuating. I hope these answers are satisfactory, and I hope my presentation also helps clarify a few of the points you might have. Thank you again.
Thank you so much to Professor Pavesio for sending in his last session. It was a really great one for us to end on today. I will very shortly be bringing our sarcoidosis of the eye patient day to a close, but I just wanted to mention a few things before I let you all go and enjoy your evening. First of all, I've had a couple of people ask about whether this is going to be recorded, and the answer is yes. We have recorded the whole day. So usually takes us about a week or two to get the recording ready and get the whole day transcribed, but it will be available in the next week or two on our website and on our YouTube channel. So if you just go to YouTube, search Sarcoidosis UK, you will find it in a week or two's time. And you'll also find all of our previous patient days as well. So if you would like to go back and watch some of our previous events, please do that. Next up, a couple of thank yous. Thank you to all of the amazing speakers who gave up their time to share their expertise with us today. I'm sure I speak on behalf of everyone watching that this has been a really invaluable event, and we really appreciate your time and everything that you're doing for sarcoidosis patients. I'd also like to say a huge thank you to everyone who's joined us and watched along with us. If you have joined us and you found this event useful, please do consider making a donation to Sarcoidosis UK. We really would not be able to put on events like this or do any of our vital work without your support. So if you are able to, please do go to sarcoidosisuk.org/donate to make a contribution. And finally, a big thank you to Brogan, who you can't see on screen today, but has been working really hard in the background to make sure all of this is working nicely. So thank you to Brogan as well. Thank you very much for listening. Please do get in touch if there's anything we can do to support you. We really are here to support you in any way that we can. You can contact us through our website, on the phone, or if you want to reach out to me directly, you can get me on leo@sarcoidosisuk.org. Thank you so much for joining, and please do enjoy the rest of your evening.